Emergency meeting. I'd like to start before we get into the superintendent's presentation on COVID-19 in our schools for this school year. We have several medical providers with us and public health officials that have been able to join us. We have a couple here present with us, but we also have a couple on the phone, and they are quite busy, as you can imagine. So I'd like to start with them. What I'll do is I'll have each of the doctors or public health officials, please, if you would introduce yourselves, tell us a little bit about your role and your position, and then if you have any other pressing information you feel like the board should know, and board members, I'll give you each an opportunity if you have questions for the healthcare and public health officials while they're with us today. So think about those or jot those down. We'll go ahead and start with folks on the phone. Dr. Mobeen Rathor, are you there? Dr. Rathor? Okay. Dr. Sunil Joshi, are you there? Okay, we'll come back to the people on the phone. With us, maybe. Present with us here in the auditorium, we have Dr. Goldhagen. Thank you for joining us. I know you spoke during public comment, but would you please remind us of your position and affiliations?
Right now, I'm Professor of Pediatrics, University of Florida, and I was the Health Department Director here for about 13, 14 years.
Thank you so much. And Mr. Rubio?
Yes, hi, I'm Ernesto Tito Rubio, and I'm the interim the interim administrator for the Duval County Health Department.
Thank you, Mr. Rubio. Did we have the physicians on the phone or doctors?
Apparently they're there. They're thinking they may have stepped away.
Oh, I heard something.
Can you guys hear?
Yep. Is that you, Dr. Joshi?
Yeah, that's me.
Thank you for being with us on the phone. I know you had to leave. Can you please state for us your title and affiliations?
Yeah, I'm Sunil Joshi. I am a practicing allergist and immunologist here in Jacksonville, and I've been practicing for 16 years.
Thank you, Dr. Joshi. Dr. Rathor, are you there?
Yes, I'm here.
Hi, Dr. Rathor. Can you go ahead and tell us about your titles and affiliations?
Yeah, well, I have many affiliations. I'm Professor of Pediatrics at the University of Florida College of Medicine, Jackson, and Director of the U.S. Center for HIV/AIDS Research, Education, and Service. I'm also Chief of Infectious Disease and Hospital Epidemiologist for Wilson Children's Hospital and co-chair of Baptist Health System Infection and Prevention Control Committee. I'm also the past president of the Florida chapter of the Medical Academy of Pediatrics and Duval County Medical Society. I've been advised to let all of you know that what I say today may or may not represent the opinion of my employer and affiliated organizations, and I'm here to completely as a citizen of Florida and Duval County, and I've been in practice and living in Jackson for more than 30 years.
Thank you, Dr. Rathor. Thank you, Dr. Joshi and Dr. Goldhagen and Mr. Rubio for being here today. What I'd like to do while we have the opportunity to have the healthcare providers or the medical professionals with us is just hear a little bit about what you're seeing, what we're seeing in the communities, what we're seeing at the hospitals, and any other pertinent information you feel like this board should be aware of as we consider masking requirements here today. Dr. Joshi, if you wouldn't mind, we'll start with you.
Okay, great, and thank you guys so much for giving me the opportunity to speak. I think when I spoke to you all before, I'd mentioned that I was born and raised here in Jacksonville. I went through the Duval County Public Schools, and I'm a proud graduate at Terry Parker High School. And I have two children that attend Duval County Public Schools as well. And I do want to acknowledge the fact that during the 2020-21 school year, the Duval County Public Schools put in place an extensive mitigation strategy that included physical distancing in the classrooms, cafeteria, buses, hand washing, regular disinfecting of tables, tabletops, and desks, and yes, masks for all of the students. This aggressive mitigation strategy was by all measures successful. Were you able to prevent every single case of COVID-19 last year? No, but certainly helped to maintain the curve and kept the curve flat and minimize the spread of the virus in an effective way to mitigate the spread so that our children were not sources of larger community spread. It seems like there are some mixed messages about whether these interventions that were put in place last year made a difference in mitigating the spread of COVID-19. Why are there mixed messages? I think it's because last year was actually our very first year dealing with this novel virus. We did not have previous years to compare to, so it becomes very hard to make judgments based on just 1 year of intervention. However, it is critically important to recognize that COVID-19 is a respiratory virus, much like influenza or the flu. Did these mitigation strategies that were put into place last year make an impact on the flu virus, which we know has a long-standing track record of being seasonal in nature, in particular between November and April of every year? The answer to that is unequivocally yes. In fact, the data from local hospitals suggests emergency room diagnoses for influenza decreased by at least 75% in the 2020-21 season compared to the average of the previous 3 years. Also compared to the previous year, 2019-2020, when about 10 to 12% of all emergency room visits for people between the ages of 5 and 18, for children between the ages of 5 and 18, were due to influenza-like illness. In 2020-21, this is less than 2%. So an 80% reduction in influenza-like illnesses presenting to our local emergency rooms. So something worked, and I credit what the Duval County Public Schools did last year in recognizing so that we can recognize that was an effective strategy of reducing respiratory viruses. Please do not forget that for the entirety of August of 2020, Duval County Public Schools had a combined 10 students and faculty who were positive for COVID-19. 10. As of Friday, just 3 days ago, we had 589. That's 60 times the number of folks that were positive a year ago at this time. On Saturday in the state of Florida, there were 65 children admitted on Saturday to the hospital with COVID-19, and yesterday there were 45 additional admitted in the state of Florida. I think it's important to recognize that about 20% of the weekly new COVID-19 cases in the U.S. are due to children because we have been unable to vaccinate. We have been unable to vaccinate many school-age children. We must recognize that the mitigation of this pandemic has to address the role that children play in the ongoing spread of this virus. Vaccines, of course, provide fantastic protection against the Delta variant. However, breakthrough infections are occurring even in immunized individuals. It then becomes important to block the rate of transmission from children to adults. If we are able to protect the kids themselves from infection, it also protects the vulnerable household contacts and other people in the community that they interact with as well, such as their coaches and their teachers and their music instructors, where they learn how to play guitar and the flute and piano, etc. Most importantly, we must protect our children themselves from COVID. We have to get over the inaccurate and overplayed thought that COVID-19 is an insignificant infection in children. That is simply not true, especially with the Delta variant. Most recently, the American Academy of Pediatrics noted that in the period of May 2020 through July of 21, roughly 400 children died of COVID in the United States. That's comparable to what we see with the seasonal flu, which we have a vaccine for. In this case, children under the age of 12 are not able to get the vaccine. The United Kingdom data suggests that the Delta variant is 225% more transmissible than the original virus, which is what we're basing all of our decisions on from 2020. This variant can be spread from one person to 7 different people. And if you think about one person in a classroom having COVID-19, and get to 7 others, that's about 1/3 of an entire class if we have 20 people in our class. Last year, that ratio was 1 to 3. So that is a big difference. And so I suggest to you all that you did a great job last year at protecting our children. We are seeing hospitalizations go up here in Northeast Florida. They have trickled down in the last few days, which is great news. But we are at a critical mass in hospitals throughout our county and throughout our community. You have seen the pleas from emergency room physicians and hospitalists and hospital CEOs for the last 6 weeks. Our hospitals are near capacity, and this is not just about the children. It's about the spread that occurs through the community as a result of children passing it on to vulnerable populations as well. So that's my statement, and I thank you.
Thank you so much, Dr. Joshi. Dr. Rathore.
Thank you, Madam Chair, members of the school board, Dr. Green, and ladies and gentlemen. Thank you for the privilege of allowing me to speak to this august body on this vital issue for our children and our community. Earlier I told you my affiliations. What I want to state is that I've been an advocate for children throughout my professional career and will continue to do so. I have always respected opposing views. To paraphrase late Senator McCain, those who hold opinions different from me are not my enemies. I hope we have a civil discourse on this issue and many other issues that we will shortly face. I was going to present lots of things, but I will not repeat what my good friend Sunil has eloquently said and what several of my fellow physicians have already stated earlier. I was asked to speak today on the value of masks in protecting our children and making our schools safer. Before I delve into the issue at hand, I want to take a couple of minutes to set the premise for my presentation. First, there is no doubt in anyone's mind that in-person school is optimum for learning, mental health, social growth and well-being of children, and all children should be afforded their right for in-person schools. Second, nothing is guaranteed to be absolutely safe in life. Driving to school or work in an automobile is safer by having a strong and well-engineered chassis of the vehicle, using the seat belt, and having an effective airbag. If everyone follows traffic rules without exception, we all hope to have a safer journey to our destination. Making schools safer is not any different than making our automobiles safer, which makes our journey safer. Think of social distancing as a well-engineered chassis of your automobile, which keeps you protected from infectious organisms. The seat belts as masks always present to protect you in case some virus slips, the social distancing, and airbags as vaccines, so that if your body is in fact infected by the virus, your vaccine, like the airbag, will protect you against serious consequences. However, all of this can only work if everyone follows the same rules. My ride to work is bound to be tragic if some drivers can opt out of following traffic rules and do not stop at red lights, even if I am in a Volvo with 5-point seat belts and smart airbags. Masks work best when used in combination with other mitigating measures. That should be part of the comprehensive plan, which includes vaccination, social distancing, good hand hygiene, correct cough etiquette, good ventilation, contact tracing, and testing and isolation and quarantine when necessary. Ladies and gentlemen, I can quote you reliable and robust scientific studies about effectiveness of masks to protect against coronavirus, like the one done in 13 public schools in North Carolina that were reported by our colleagues from Duke, or the one in Georgia that looked at 90,000 children in schools, in public schools, that was reported by the CDC, both of which showed that masks are effective. I know if one does not support masks in school, one can find some studies to support one's position and find holes in the opposite side evidence. That is the nature of debate. If my car has a problem, I will take it to a mechanic, and if my AC is not working, I will have an AC technician look at the AC. Science and medicine are no different. For scientific evaluation of a medical subject, it is important to pay heed to those who have spent their lifetime studying how to prevent, control of infection, prevention, and transmission, and care for children. All reputable professional aid organizations, including the CDC, Infectious Disease Society of America, Society for Healthcare Epidemiology, Pediatric Infectious Disease Society, and the American Academy of Pediatrics, and also your own Florida chapter of the American Academy of Pediatrics, have recommended masks for children attending school in person. No one has argued that it is better not to have to wear a mask in schools. By the way, I would prefer not to wear a mask all day when I am at the hospital, when even though I'm vaccinated, and as physicians reported from what Dr. Nicole Alexander had stated. However, I want to protect my patients, my coworkers, and myself from this infection, so I'm happy to wear a mask. You may ask why, if you are protected by vaccine, you are concerned about infection, since infection may not be serious. Well, I can still have the long-term complications after COVID infection, or as it is called, long COVID. That brings me back to our children. I pray to God Almighty that none of the 503 children infected in less than 2 weeks of school, 9 days to be exact, show up at my hospital with serious illness, are admitted to the ICU or intubated to be placed on a breathing machine. I just cannot bear that and see the suffering of the family and parents. Or my greatest fear, God forbid, these children die of coronavirus infection that could have been easily prevented by masks, vaccines, and other mitigating procedures. Also, please do not forget that there are numerous children who are less than 12 years of age and are not so lucky to be vaccinated. I have over 300 children less than 12 years of age who are waiting to participate in a research trial that we are conducting for vaccine in that age. The month of July was the worst month for hospitalization for children in Jacksonville since the start of this pandemic. More children were hospitalized in Jacksonville in July than any other month since the start of the pandemic. August is not looking any better. A few weeks ago, CDC reported that there were 203 children hospitalized with coronavirus across the United States. At the same time, there were 22 children hospitalized with COVID in Jacksonville. That should speak volumes. Today, there are 7 children who are hospitalized in Jacksonville because of coronavirus infection. But I digress. I do not just worry about acutely infected children, but also all those children who will get the dreaded MIS-C, or multi-system inflammatory syndrome of childhood, that can be more serious than even the acute infection. Let us not forget long COVID, which surely many of these children will get, even if they do not get serious acute disease or MIS. Now, if I get COVID-19, I may have to deal with it for 10 or maybe 20 years if I live that long. A 6-year-old may have to deal with the complications of COVID for 80, maybe 90 years. Do we really want our children to go through that misery? Let us not fail our kids. When the future generations remember us, let them remember us as those who protected our most precious and most vulnerable asset, our children, and not those who failed to do so because of misinformation or a misinterpretation of evidence, science, and data, which overwhelmingly supports the use of masks in the prevention of transmission of infection. Rather than walking through all the studies, I would refer you to look at the cdc.gov and aap.org to review the evidence. There are studies from the United States, from Germany, from Japan, many studies that have shown that masks work. I know some people have reported what Dr. Michael Osterholm said. What he was saying was that masks are an hierarchy. N95 is the best mask, but it doesn't mean that other masks, other facial coverings don't work. They perhaps don't work as well. So I would end by saying, please protect our children. I've spent my lifetime educating for children, and this by far seems to be the biggest challenge facing our children in recent times. Thank you and God bless. We'd like to answer any questions.
Well, thank you again, and I don't have much more to add than Dr. Joshi and Dr. Rathore mentioned. The fact, it's a simple fact. Children get COVID. Right now, Jacksonville is the epicenter for that, for COVID infection in the country. That kids get sick with COVID, that they get hospitalized with COVID, that they end up in the intensive care unit with COVID. They get long COVID. Somewhere between 10 and 30% of children actually will develop long COVID. What we know now is that many of the markers that we're seeing in children with COVID would indicate that there's a very significant chance that they will carry this disease or have an impact of this disease for a long period of time and actually into adulthood. The MIS-C, the multisystem inflammatory disease that we see in children, need to remember that that occurs 6 weeks or more after a COVID infection, and many of the children that get MIS-C actually are asymptomatic. So we're dealing with a disease that is the most significant disease that I've seen in my public health and and clinical experience. The studies that many of the people that presented today are just bogus, number one. Number two, many of them are misrepresented. As an example, the statement that Mobeen mentioned related to Michael Osterholm, it wasn't that masks don't work. It was that N95 masks work better. One person was talking about ivermectin, that we should be treating everybody with ivermectin, and that we have a treatment for this disease. While he was talking about ivermectin, I was receiving another study that indicated that ivermectin doesn't work. So the decisions need to be evidence-based, based on the best data and science, and that's what we would plead with you to consider as we move forward with this disease. The other part of this is that this is just a dress rehearsal, right? COVID-19, which is now, I'm suggesting, be called COVID-21 because the Delta variant is fundamentally different from the initial strain and Alpha. We will have another strain. And unless we can implement evidence-based public health policies that will protect, in our case, children, then what chance do we have in the future in addressing issues that will unfold? And the reality is so many people here today said, you know, that there's a small percentage of kids that are infected, that kids don't get sick, and on and on. Those are just not true statements. Kids get sick. Kids are increasingly becoming sick and sicker with the transmissibility and virulence of the Delta variant. And so we're just seeing the tip of the iceberg. And for every child that we see, they say, well, only 500 kids died, or that we only have 20 kids in the hospital. For every one of those children that are hospitalized, there are hundreds and hundreds of others who are infected, and the chances of them, number one, resulting in long-haul COVID, and number two, being impacted decades later, are very significant. And we can stop this, or we can limit it with the use of masks. Now, there were lots of statements about the detrimental impact of mask wearing. If you go on the American Academy of Pediatrics site, you'll see the evidence as to what the impact of mask wearing is, and it's essentially none. Kids who are born congenitally blind develop language and language skills at the same rate as kids who see. Kids who grow up in conservative Muslim communities where they're taught by women who have burkas and their face covered, develop language skills exactly the same way as others do. So that the evidence that there is an impact from mask wearing is essentially non-existent. There is some evidence that social emotional development might be slightly impacted, but kids develop alternative approaches for social and emotional development. And so there are some psychologists who are saying that actually there's some benefit to wearing masks. I'm not going to suggest that, but there's no significant evidence that mask wearing is detrimental.
Thank you, Dr. Goldhagen. Mr. Rubio, did you want to weigh in this conversation at this time?
Well, the only thing that I'd like to state is as Dr. Goldberg has said, that we are dealing with a much different variant now than we were last year. So to look at data from last year and to try to make decisions based on last year's data, I think you're doing a disservice. You have to understand that the variant that we're dealing with today is much, much different. Thank you.
Thank you all for sharing your thoughts and medical perspectives with us, public health perspectives. Board members, I want to give you all an opportunity to ask the professionals any questions that you might have. I will go ahead and take anybody who's ready or has some questions that we'd like to have addressed by our health officials. Anyway, let's see, Dr. Coker.
Thank you, through the chair, to our physician here. Thank you for, well, first off, to all of the physicians that have joined us, thank you for contributing to the conversation and helping to inform us as we make this decision. So first, again, thank you for your time. You spoke just a little bit about we've heard about from Dr. Rothor about the possible of decades-long effect for children who contract COVID. You just spoke in regards to wearing of masks and some of the social, emotional aspects of wearing the masks. If you were to look, and we hear a lot about, some parents talk about microbes and whatnot in the mask that are calling respiratory and whatnot. Can you speak to that specifically, short-term, long-term effects? Is there anything to be concerned about there?
Yes, I can speak very eloquently about it. There's no evidence that there's any impact from microbes, from moisture, from any medical outcomes or medical issues, microbiological issues from wearing masks. So the data just isn't there. The evidence base is, in fact, exactly the opposite. There was a woman that talked about wearing masks and resulting in changes in high arched palates and changes in facial structure and so on. With one hat on, another hat on, I'm the medical director for our craniofacial program, our cleft and craniofacial program here. You don't develop a high arched palate from wearing a mask. And there's no evidence that there's any impact on facial deformities from wearing a mask. It's just not true.
Thank you, Dr. Goldhagen. Dr. Joshi or Dr. Rathore, did you want to comment on the risks of masking or the medical side effects, perhaps, of masking? I'm not hearing any response. So, Dr. Coker, did you want to continue your questions?
I'm good for right this minute.
Oh, was there did I miss something?
Can I make another? So one of the issues as far as the language development, early language development is important for sure. And if you go on the Academy's website, you'll see some comments about that. But most families aren't wearing masks in the home. So that the time spent by parents and face-to-face visual opportunities for the child to see the face of the parent are sufficient enough to ensure that, in fact, there's normal language development. So a statement that was made that, yes, having a child able to see the facial expressions and respond, the serve and return type of reflex that we talk about, the time spent by parents in unmasked in the home appears to be sufficient to ensure that, in fact, that aspect of language development unfolds. But again, kids who are congenitally blind develop language skills at the same rate as children who live in families whose parents obviously aren't, who are not blind, right?
Thank you, Dr. Goldhagen. Board Member Jones.
Excuse me. Thank you, Board Chair. Could someone speak, and I've known Dr. Goldhagen for a number of years, and I appreciate you and all the other physicians and the health department being here and adding to this conversation. I hear a lot about positivity rate and the role it plays, the positivity rate and the role it plays in whether you mask or don't mask and how that's changed over the last month. Can someone speak to that for me, please?
You're looking specifically at the local positivity rates?
Right.
And whether or not certain mitigation measures should be in place?
Right.
Maybe Mr. Rubio, if you wanted to
Yes,
take
Chair.
that, and then Dr. Goldhagen.
Chairwoman Anderson, I'd be happy to address your question on that. Obviously, when we look at positivity rates, what you're looking at is the percent of people who were positive to the percent of people who were tested. So by no means is positivity rate on any given day the positivity rate within our community. But we use it as an example to be able to gauge and understand what is going on in community transmission. In the last month of August, yes, ma'am.
No, that's okay. Go ahead.
In the last month of August, we have probably been averaging around 23 to 25% positivity rate in Duval County. And that fluctuates from day to day. We might be down to 19, we could be up to 30, right? So I'm just trying to give you a ballpark number of where we are with that. And what that is really reflecting is like exactly what you heard one of the doctors say, that with this Delta variant, where before we might see one positive case infect 2 or 3 people, we believe now with the Delta variant, one positive is infecting 7 people to 9 people. All right? So anything that we can do to mitigate that spread is going to help us. And that's what we're talking about, I think, today.
Thank
So,
you, Doug.
as a follow-up, as I also understand that the hospitalizations and the deaths that sometimes follow are lagging indicators of the positivity rate. So if you had 100 people test positive, the people who will be hospitalized, the increase in that number will be reflected several weeks or months later. Is that correct, too?
So to answer that part of the question, Chairman, is right. Anytime we see infections, it could take up to 2 to 4 weeks before we'll see hospitalizations from that. But make no mistake, Duval County probably has about a third of all hospital beds have a COVID patient in them. Just let me state it that way. So about 30% of all beds currently taken in our hospitals today are taken by COVID patients. Now, will that get better? I think what we're hoping is that it does. There are some mitigating circumstances that are being done. You know, the governor started Regeneron. We're hoping that that will reduce the number of people who become hospitalized, because that is a treatment that you do once you have illness, but prior to you have hospitalization. So my answer to that is we'll have to wait and see. And then, of course, deaths follow behind hospitalization. So the question I've been asked is this Delta variant more deadly than what we were seeing back in December, January of last year? And the answer to is too early to tell you. Don't know.
But,
Dr. Goldhagen.
yes, I think the statistics are actually worse than Tito is suggesting. I know that at least last week, Baptist system has, I think, 900 beds in their system, and over 500 of them were filled with COVID cases. The University of Florida has a substantially more than a third of their cases actually filled. And although Tito's right that the data is not firm, all of the data would indicate now that the Delta variant is far more virulent than the Alpha and the previous strains. And so that data is now unfolding, data coming out of Canada, data coming out of Scandinavia. There are Israel as another example. So the data is pretty clear now that this virus is more virulent, far more virulent. Now the issue of deaths from the disease is impacted by the fact that in the initial phase of the pandemic, it was older people who were being impacted. So the death rate from the Delta variant will probably be less because it's younger people that are getting infected. However, in the initial pandemic, younger people weren't dying. So the death rate among younger people is far greater with the Delta variant than with the previous strains. The total death rate is less because the older people tended to die more frequently.
Thank you. Thank you for that. Dr. Rathore, Dr. Joshi, do you have any additional comments specifically on which data points I think are helpful indicators for us and when we're looking at community spread?
Are you able to hear?
Yes, Dr.
Little bit,
Rathore.
yeah. Can you ask us the question again? I can hear a question.
Sure. So the question was specifically around which data points are good indicators of the level of spread in the community. I think Board Member Jones asked about percent positives. I know we also have other data points like cases per 100,000, and then how that relates to hospitalizations or lag time in that reporting data.
Yes, can you hear me?
Can you hear me?
Yes, I can hear you. Can you ask the question again, ma'am?
I apologize.